What's up everyone? Dr. Kofi here, and welcome back to the channel where everything medicine is simplified. You know how we do it here, right? You watch for 30 seconds and then take some time to like and share our video and then subscribe to the channel if you have not done that yet. And so this is the third video in our ECG interpretation series, and in this video we will discuss the P wave and how to identify atrial anomalies like right atrial enlargement and left atrial enlargement. Let's get started, and before I forget, kindly put us on post notification so that you don't miss any of our newly uploaded videos. Very good. And so let's quickly go through the proposed steps of ECG interpretation. And so first, you start with demography. You identify the patient by name, age, and sex so that you can be sure that the ECG report you are holding belongs to the right patient. And next, you check for the standard calibration and speed. This is followed by the calculation of the heart rate. And then we have the rhythm. And then the next step is to determine the cardiac axis. Kindly note that these steps have been dealt with extensively in our previous videos, and so kindly find the links to those videos in the video description below. After determining the axis, we move to the waves, and for the waves we are interested in the P wave, the QRS complex, and the T waves. And from the waves you move to the intervals. We have the PR interval and the QT interval, and then the segments. And for the segments, we have the ST segment and the PR segment. Lastly, the overall impression. And as mentioned earlier, we are on step 6, and in this video, we will be treating the P wave. Alright guys, and so please recall that the P wave represents right and left atrial depolarization. Now when describing the waves on the ECG, whether the P wave or the T wave or the QRS complex, there are 3 essential features we are interested in. And I remember these features using this thinking that when describing waves on the ECG, get mad at them. Yes, get MAD, mad. And so the M represents the morphology of the wave. The A represents the amplitude of the wave, which is the y-axis component of the wave. And then the D represents the duration of the wave, which is the x-axis component. And so for the P wave, we are interested in the morphology of the P wave, the amplitude of the P wave, and then the duration of the P wave. Very good. Please do not forget to like and share this video, and then subscribe to our channel if you have not done that yet. Now let's take a look at what the P wave usually looks like. This is our ECG strip, and this is a typical P wave. Now please note that this P wave is not drawn to scale but has been enlarged for demonstration purposes. And so please recall that we said the right atrium depolarizes first before the left atrium. Remember that principle. And so, if we divide this P wave into 3 parts, the first 1/3 represents the right atrial depolarization because it is the first part to depolarize. And then the last third represents the depolarization from the left atrium. And so you are wondering what the middle third represents, right? Now, when the right atrium is depolarizing and is getting to its end, the left atrial depolarization also begins. And so the middle third is a combination of the end of the right atrial depolarization and then the beginning of the left atrial depolarization. The P wave is best assessed in leads 2 and V1. This means if you are looking for atrial anomalies, it is best to pay attention to leads 2 and V1. Leads 2 and V1. While granting that fact, anomalies can also, or atrial anomalies, can also be assessed in the other inferior leads like AVF and then lead 3. but typically lead 2 and lead V1. Great. And so let's get mad at the P wave then. And so mad, M for morphology. And so usually the P wave is positive in all leads except for lead AVR. And I hope you understand why. If you don't, kindly visit our previous videos to get the underlying principle here. And so usually the contour of the P wave is smooth. It has a smooth contour, but it may be notched, especially in the limb leads. But kindly note that for most of the times it is a smooth contour. The P wave in all leads is monophasic, and what this means is that it points only in one direction. And this occurs in all leads except for lead V1, in which the P wave is biphasic, meaning it has a positive and a negative component. We will demonstrate this normal morphology using this diagram. So this diagram shows the P wave in leads 2 and V1. So here in lead 2, you see the P wave here is pointing in the positive direction. And number 2, it is monophasic. It means that it only has one direction. Now contrast this monophasic morphology in lead 2 with the biphasic morphology in V1. You can see that the P wave has a positive component and a negative component. And so the first component, which is the positive component, represents the right atrial depolarization. And then the terminal negative component represents the left atrial depolarization. Now, because these components represent the different atria, this makes this lead, V1, the most suitable lead to assess for individual atrial anomalies. Good. And so regarding the morphology of the P wave, some of the abnormalities that can occur include an absent P wave. And one of the common causes of an absent P wave on the ECG is atrial fibrillation. Just one of the common examples, but there are several examples. Another abnormal morphology is that the P wave could be fibrillatory. And this looks like the blade of the hacksaw. Again, the most common cause here is atrial fibrillation, meaning atrial fibrillation can have an absent P wave or a fibrillatory P wave. We will discuss atrial fibrillation into details in other videos, but for now, let's move to another abnormal P wave morphology. The third one is that the P wave can be inverted, and an inverted P waves can be seen in focal atrial tachycardia. We will look at that later. Then, the P wave can have varying morphologies on the same lead, meaning, for example, in lead 2, the first P wave may be inverted, the next may be absent, and the next may be fibrillatory. And so you have varying P wave morphologies. And this may be found in multifocal atrial tachycardia. It means that the rhythm is coming from different foci or foci in the atrium. We will see all these things again when discussing arrhythmias, but just be aware of some of these abnormal P wave morphologies. And so we are still getting mad at the P wave. So we've done M, morphology. So the next thing is A, amplitude. And here for the amplitude, we want to know how high the normal P wave should be. And as said earlier, we assess the atrial anomalies using the two leads, lead 2 and V1. Now in lead 2, remember the P wave is monophasic here. And the P wave should not exceed 2.5 millimeters or 2.5 small boxes high. It shouldn't. The highest amplitude you should get in this lead is 2.5 millimeters. If it exceeds 2.5 millimeters, then there is a problem. We will look at what that represents. Now, lead V1, you know the P wave in this lead is biphasic, right? It has a positive deflection, which represents the right atrial depolarization, and then a negative deflection, which represents the left atrial depolarization. Now, the positive deflection, should not exceed 1.5 millimeters or 1.5 small boxes high. The negative deflection should not exceed 1 millimeter or 1 small box deep. So the way I like to think about this is that for lead 2, you know that the maximum height the P wave should get is 2.5 millimeters. And this is a combination of both the right and the left atrium. And so when it comes to lead V1, if the first deflection, which is for the right, should not exceed 1.5 millimeters, then it makes sense that the negative deflection should not exceed 1 millimeter or 1 small box, because when you add the amplitudes of the two atria, you should get 2.5 millimeters, right? And so generally, I want to say that a high amplitude represents right atrial enlargement, especially in lead 2. So kindly keep this principle in mind, a general principle. The last thing is the duration of the P wave. For the duration, the P wave should not exceed 3 small boxes or 3 millimeters wide. Yes, it shouldn't exceed 3 millimeters or 3 small boxes wide. What I use to remember this is when you turn 3, the number 3, you get the letter W, which stands for width. And so it makes me, or it helps me remember that the P wave should not exceed 3 millimeters. And so having seen the normal parameters of being marked at the waves, or in this case the P wave, let's see how they can help us identify atrial anomalies. But like we made a general statement about the amplitude, we want to make a general statement here that an abnormally longer duration speaks for left atrial enlargement. Remember, we said an abnormally high amplitude, especially in lead 2, speaks for right atrial enlargement. So if you have an abnormally long duration P wave, you'd have a left atrial enlargement. And so the first atrial anomaly we want to look at is right atrial enlargement. Now for the atria, if it is hypertrophied, we still see it is enlarged. So right atrial enlargement. Now how do we identify right atrial enlargement of the ECG? Remember, we use lead 2 and V1. And so for lead 2, if you have the P wave greater than 2.5 millimeters or 2.5 small boxes high, then we have right atrial enlargement. And this morphology, we mean the P wave being greater than 2.5 millimeters in amplitude, is known as Ppulmonale. Now I always remember that it is pulmonale because the pulmonic valve is located in the right side of the heart. Then apart from lead 2, you can use V1 also. Remember we said V1 has, or the P wave in V1 is biphasic, and the first positive deflection is for the right atrium, right? And so if you have an amplitude of the first or the positive deflection more than 1.5 millimeters in V1, it also speaks for right atrial enlargement. Let's see this on a diagram. The P wave in lead 2 here is obviously taller. That is, this would be obviously more than 2.5 millimeters on the ECG strip. And then look at V1. You can see here that the first positive deflection is also unusually tall. That is, it will be taller, or it will be more than 1.5 millimeters in height. And so if you want to identify right atrial enlargement, just look at lead 2. The P wave would be more than 2.5 millimeters high, or look at lead 1, or V1, you will see that the first positive deflection, which represents the right atrium, is more than 1.5 millimeters in amplitude. Good. And so on this slide, let's demonstrate right atrial enlargement on an ECG paper. Now this is an ECG reading of a patient. And so we move straight to lead 2 and ask how many small boxes high does the P wave cover. And here you can see that the P wave covers more than 2.5 small boxes or 2.5 millimeters. And this is right atrial enlargement. Or go to V1 and examine for the first positive component if it's more than 1.5 millimeters. And here, although it may not be clear here, the ECG actually has the first component of the P wave in V1 more than 1.5 millimeters, and this is right atrial enlargement. Good. Now let's look at left atrial enlargement. And so the leads we pay attention to, of course, lead 2 and V1. What does lead 2 show? Lead 2 will show a bifid P wave. This means that the P wave has 2 peaks. In other words, there is a notch in the P wave. And then these peaks are at least one small box apart, or they are separated by 1 millimeter apart. And then, more importantly, the duration of the P wave is more than 3 millimeters wide, or 3 small boxes wide. This morphology is known as Pmitrale. And I remember it is Pmitrale because the mitral valve is found on the left, and so Pmitrale. Remember, we said that the morphology of right atrial enlargement in lead 2 is Ppulmonale. How about V1? What will this show if there is left atrial enlargement? Now remember, the negative component speaks for the left atrium, and so here the criteria is that the negative part would be more than 1 millimeters deep, and then the duration or the width will be more than 1 millimeters or 1 millimeter wide. In other words, it will be more than 40 milliseconds. Now let's illustrate these criteria on the next slide. Very good. Kindly take a break here and then like, share our video, and subscribe to our channel if you have not done that yet. And then come back, let's continue with the discussion. Now, this is a diagram to illustrate and simplify how left atrial enlargement can be identified on the ECG. So the first waveform is found in lead 2, and the next or the other waveform in V1. Remember, we said that the normal morphology of the P wave is that it is a smooth contour, or it has a smooth contour. However, occasionally, especially in the limb leads, it will be bifid. The difference between that morphology and then that of left atrial enlargement is that the left atrial enlargement would have an abnormally wide P wave as well, and then the peaks will be separated by at least one small box. But let's look at the P wave in this diagram. So here you see that the P wave is bifid, and then the space between those 2 peaks are separated, or should be separated, by at least one small box wide. And more importantly, the entire P wave would have a duration more than 3 small boxes or 3 millimeters. And so if you have this, then you have left atrial enlargement. And then you go to V1. You see that here in V1, the negative component should be more than 1 millimeter deep, or one small box deep, and then the width is more than 1 millimeter wide, or more than 40 milliseconds. So that is how to identify left atrial enlargement. And so to demonstrate this, let's see this ECG. Now, to identify left atrial enlargement, move to leads 2 and then V1. See the width of the P wave here. It is more than 3 millimeters, and the P wave is notched, and this is known as Pmitrale. And then, although it is not clear here, the space between the 2 peaks is separated by at least one small box. How about V1? Look at the negative component and you realize that it is wider than 1 millimeter, and then more than 1 millimeter in depth. So if you have these features, then you can comfortably diagnose left atrial enlargement on the ECG. Now, in certain instances, you may find that both atria are enlarged, known as biatrial enlargement. And you would agree that in such situations, you will see features of right and left atrial enlargements combined, right? And so let's illustrate this with this diagram. And so here again, the first P wave here represents the P wave in lead 2. You see that the P wave is abnormally high in amplitude, which speaks for right atrial enlargement, and also unusually wide with a notch, which speaks for left atrial enlargement. And so this is a biatrial enlargement. And then pay attention to the P wave here in V1. First positive component is abnormally high, that is more than 1.5 millimeters high, and that speaks for right atrial enlargement. Then the negative component is wider than 1 millimeter, and then more than 1 millimeter deep, and that speaks for left atrial enlargement. And so this is how to identify biatrial enlargement on the ECG. Very good. And so on this slide, I want to interpret a sample ECG report from step 1 to step 6, ending on the P wave, so you can appreciate our journey so far. But first, let's acknowledge the source of this ECG report. I got it online from learntheheart.com. The first thing we do here is to make sure that the ECG is a standard 12-lead ECG. Then, we confirm the identity of the patient, but there is no name here on this strip, and so let's assume the patient is a 48-year-old man, Mr. AK. And so, we begin by saying, this is a standard 12-lead ECG report of 48-year-old man, Mr. AK. After doing that, the next thing is to ensure the calibration and speed are standard. And as you can see, this strip has a standard calibration because the calibration marker here, as indicated, is 10 millimeters high and 5 millimeters wide. And also, the ECG has a speed of 25 millimeters per second. After doing that, the next is to calculate the rate. But to determine the rate, we need to determine the regularity of the QRS complexes. And as you can see, the QRS complexes here are regularly spaced. And there are 13 small boxes between two consecutive QRS complexes, or R waves, giving an RR interval of 13. And so the rate is given by 1,500 over number of small boxes. And so 1,500 divided by 13 gives 115 beats per minute. And as you know, any heart rate more than 100 represents tachycardia, or increased heart rate. Then after calculating the rate, the next is the rhythm. We want to know if the rhythm is sinus or not sinus. And so, as said earlier in our previous video, we use the rhythm strip, lead 2 or V1. And so here we would like to use lead 2. And as you can see, the waveforms of lead 2 here are identical, so it forms a rhythm. And more importantly, each QRS complex is preceded by a normal morphology P wave, and the PR interval here appears constant throughout, and so this is a sinus rhythm. From the rhythm, you move to the axis, and then using the quadrant method, which is the most straightforward, the QRS complex is positive in lead 1, meaning the depolarization wave is moving towards lead 1, and it's also positive in AVF, meaning the depolarization wave is moving towards AVF, and so it makes the axis normal. Please see our previous video if this is news to you, the calculation or the determination of the axis. Now from the axis, we come to the waves, and then we begin with a P wave. Using lead 2, let's get mad at the P wave. You see that the morphology here is normal. Why? Because it is positive in lead 2 and it is monophasic, so it is normal here. But look at the amplitude. The amplitude in lead 2 is 3 millimeters, what did we say the amplitude should be at the maximum? It should be 2.5, and so 3 millimeters is unusually high. And then the duration D, it is 2 millimeters or 2 small boxes, and which is normal because it should be less than 3 millimeters. And so adding all up, we say that this is a standard 12-lead ECG report of 48-year-old Mr. AK. The strip has a standard calibration and speed. There is sinus tachycardia of 115 beats per minute, and then the rhythm is a sinus rhythm. The cardiac axis is normal, and there is Pulmonale evidenced by an amplitude more than 2.5 millimeters, specifically 3 millimeters, and then this suggests right atrial enlargement. Good. And so thank you for watching. And like we said, the other features of abnormal P waves will be treated when we are treating arrhythmias. Thanks for watching. Please subscribe if you've not done that yet. Like, share our video, and put us on post notification. And then see you in our next video. Bye.